to this morning's discussion of Psyfeld. We're going to focus on the episode, The Dinner Party. I invite anybody to unmute. Give me an idea where you would like to start our discussion this morning.
Jimmy, I thought we were doing the slicer for today. I thought it was changed from dinner party.
Oh, did it? You're exactly right.
Okay, good.
Right, the slicer. I apologize. Yeah, that's the exact reason why we created the sub-I in psychiatry.
Oh, good. Glad I can help.
So the slicer, impressions, observations?
I would say first off, as always, I'm kind of like appalled by some of these characters and their choices in life. I think like some of the interesting ones for this one was, gosh, I'm blanking on his name, the balding guy.
George?
Yes, George. So his sort of like narcissism throughout this episode of, for instance, like thinking that this boss would remember him, thinking that also apparently nobody recognized him in the photo because of his thinning hair, and being convinced that everyone would immediately recognize him and see him. That was interesting to me.
Yeah, George has a tendency to make everything about himself. He certainly has an egocentrism that crosses the line with regard to being developmentally appropriate. As an adult, he has a very difficult time seeing through the perspective of others. And in so much as that perspective becomes clinically impairing for him, interpersonal relationships, etc., he is certainly at risk for developing a mental disorder, and that would include a personality disorder, absolutely. The idea that somebody wouldn't remember him and to be able to reassure himself really never enters his mind here, because he doesn't have the capacity. So definitely egocentric. We've discussed this before. Larry David actually provides a brief glimpse as to the potential etiology of this, because Frank and Estelle Costanza, George's parents, are frequently cast with regard to the viewers learning what that family dynamic is like, and therefore what that family dynamic must have been like as George grew up. There's even flashbacks in some episodes with regard to George when he was little, and some of the maladaptive interactions between George and his parents. So etiology, fairly well established. Of course, the details are missing. And I've said this as well. If Larry David ever had the idea of his next million dollar situational comedy, it would be young George. It would be that family environment and how maladaptive it was. Any other observations for George Costanza? I will also say this, given that we see George in multiple social situations and settings, work, interpersonal, etc., and since we follow George over 9 seasons, and then with some flashback are provided further history, his behavior and the potential causes for it do appear to be pervasive and stable, right? So there's only on one occasion, and this would be an interesting discussion as well, probably not for today, where we see a drastic change in his personality that clearly is separate from a pre-established baseline. That's the episode where he's abstinent, right? So the episode may even be titled The Abstinence, but otherwise it's incredibly stable, it's incredibly pervasive, and therefore a personality disorder really should be in the differential diagnosis. Other observations, Seinfeld, the slicer.
Oh, I would say thanks. Kruger's obsession with the slicer was pretty interesting. He was an odd character to me. He was, I think, the second time that I saw him interacting with the other characters, and it was just interesting how he was so obsessed with that slicer and how he really cared about it, and his lack of social skills in terms of he takes things very literal, I find. So yeah, that was interesting.
Yeah, so for Kramer, very frequently, the subplots that focus on this character are odd and eccentric. He becomes overly focused, if not obsessed, on things that most people don't find interesting, much less fascinating. But for him, he becomes very consumed, where it does govern his behavior for the entire episode, if not more. And if we see that level of eccentricity, it is consistent with the schizoid personality. Individuals with this condition often are very vulnerable to fads and movements that, again, I think the mainstream general population usually don't get caught up in. But Kramer does, and Kramer does quite often. The other point to make about Kramer, and just as a broader point with regard to the personality disorders, is that they do tend to share common traits and characteristics, which is why the groups are titled or labeled clusters. And in as much as there is this social awkwardness about this character, the viewer, the psychiatrist, must also entertain the potential differential diagnosis of the schizotypal personality, because Kramer, on some occasion, goes so far as to have magical thinking. Although there really is little evidence that he endures frank psychosis, no real fixed delusions, no real sensory or perceptual disturbances. So consider this character certainly a major teaching point with regard to why the American Psychiatric Association has categorized the personality disorders the way they have in clusters. And here we can focus on the cluster A personalities and the differential between the schizoid personality, the individual who lives a life of solitude, preferentially so, and that of the schizotypal personality, similarly socially awkward, but with that eccentricity of behavior that is usually referred to as magical thinking. And hence Kramer's obsession, his eccentricity in this episode becomes the title of the episode. It's a slicer.
So I was wondering about this with him, like definitely not a fixed delusion that he had, but when he was sort of tasked to be the doctor, he really took on that role very intensely. And then even afterwards, he almost started to seem like he believed that he was a doctor. It wasn't a fixed, it was like a momentary delusion, but it did almost seem to be bordering into delusion territory.
Yep. And what you're describing there, this observation that there are aspects of Kramer's behavior that, at least in this case, appear to be or at the level of delusional capacity, serves to remind us that, again, these categories that we're working from are artificial, and human behavior simply doesn't obey the artificial boundaries created by psychiatry or the American Psychiatric Association. And if we look at these types of episodes, that is these micro exacerbations of what looks like could be a psychotic break, there's a couple things to consider. And first and foremost would be a phenomenon usually referred to as stress-induced psychosis. All right, so we do know that the cluster A personality disorders, paranoid personality disorder, as well as the two we've mentioned, schizoid and schizotypal, do confer risk for developing a future psychotic disorder such as schizophrenia. But it's not necessarily a straightforward process. I mean, it certainly can be, but it's not always a linear progression like the textbook might tell you. There are episodes in which the individual will present psychotic, that is with a predisposition due to their personality disorder. An element of stress can push somebody over the line, albeit transiently. And those transient psychotic breaks are usually, again, referred to as stress-induced psychosis. And I'm wondering if that's what we're seeing here with regard to Kramer's pretty much assuming the personality of Dr. Van Nostrand.
So I would be interested to hear other people's thoughts on Elaine, because I thought she was very interesting in this episode. I thought she sort of showed different aspects of a lot of different personality disorders. One, like possibly dependent, in that she's like having to get Kramer to do everything for her, with like coming to do the outlet. Though it didn't quite seem dependent, because it almost seemed a bit manipulative, in that like she knew that it was going to hurt and she didn't want to do it herself. So she almost kind of manipulated him into doing it, but she still needed his help on so many aspects of the episode. And some other personality, even narcissism, where, you know, with the cat, she didn't even really care that much. She mostly just cared that the cat was meowing. She didn't care that it might die because it wasn't getting food because of her. She just cared that the meowing was now even worse than the alarm. So I'm curious what other, you know, personality, I saw a few other personalities, if anybody else noticed some personality disorder traits.
Any comments on Elaine?
I thought the dream she had at the very beginning of the episode was kind of interesting, and sort of ties in with the comment about dependent personality, because in the dream she clearly feels smothered by her relationship with the three other characters, but by the end she's kind of reliant on them. Like the ending scene when she's trapped in her apartment, she's relying on them to give her food and water and everything, and throughout the episode sort of relies on Kramer to help her. So.
If you wouldn't mind, just remind us of the content of the dream you're referring to. What actually takes place?
Well, she wakes up in bed, and then she sees Jerry there, and she says she needs space. And then she turns and sees George in the same bed, and then she sees Kramer come up from under the sheets, and she's like, they're all kind of basically on top of her, and she keeps saying she can't breathe and she can't breathe. And they're saying, oh, we'll be with you always, like when you're in the bathroom, when you're eating, when you're, I don't know exactly, but basically saying she can't breathe.
Let's take a comment someone made with regard to Kramer's character and his taking things literally, concretely, and let's apply that same type of mindset to this very scene. What if Elaine did continue to see these images in these different social scenarios? We're with you here and there. Taking that literally, if Elaine came to you with a chief complaint that she was experiencing this, what are some things the clinician must think through?
I think that she would need to like maybe reevaluate her friendship and like the boundaries that she has with the three of them, just because it's obviously affecting her if it's showing up in her dream. Like she might not know it, like, you know, and throughout her daily life, but obviously there's something there if, you know, things like that are happening. So she definitely needs to reevaluate that.
I think you're 100% accurate, and I think she would agree with you as well. There is more than one episode where Elaine's subplot is her realizing that she needs to reevaluate her friends and her life. And she explicitly tells Jerry and others this. And I might be wrong in the title, but it's the Bizarro episode, in which she actually does reevaluate and does engage in new friendships. So can't say you're wrong, because Larry David actually thought the same as that towards that with regard to creating at least that episode, but certainly shared by Elaine. Absolutely.
I thought it was interesting though that she immediately after waking up from the dream goes over to Jerry's apartment and, you know, like lays down on the couch exhausted. So it seems like it's that almost like that morning she's doing this. So she feels that way, but then she doesn't engage with it or act on it. She goes immediately to them.
Doc, I'm having these episodes where I'm having these very vivid dreams. They seem, again, I want to take this concretely, they seem to invade other aspects of my life outside my bedroom. And the only thing I can do is plop on a couch. I'm so exhausted all day. Clinical thoughts?
I think it would be important to also evaluate for some level of depression, where, you know, she's having maybe increased or decreased sleep, and, you know, that lack of sleep is kind of causing these vivid dreams that she's waking up from and experiencing.
Yep. Yeah, I think certainly as she is sitting or is in that office setting with you, you are absolutely going to provide the psychiatric review of systems. You're going to go through dysphoria and depression, anhedonia and loss of interest, SIGI caps, inquiring about an elevated, expansive, or irritable mood, certainly inquire about anxiety, as well as psychotic symptoms. Absolutely, no doubt about it. And not to necessarily get too specific here, but generally speaking, she is definitely going to endorse some of these. Which ones is probably, again, a little bit beyond our conversation, but she is likely to endorse some of them. But again, the reason why she is seeing you, the reason that brought her to your appointment or to your office appointment that day, is that she's had this vivid dream. They are reoccurring. They are reoccurring outside of the bedroom. And all she can do is just plop on couches these days and just feel absolutely exhausted.
I would want to inquire a little bit about PTSD symptoms and the content of the dream, any past trauma, if she's experiencing any flashbacks, because that could be contributing to waking up from these dreams and just feeling extremely affected by them throughout the day.
For clinical interviewing, because, and especially in medical school, when we give you little to no time to actually provide a comprehensive psychiatric evaluation, when you provide that psychiatric review of systems and you ask an individual, do you consider yourself a nervous person? When they say yes, you can then go forward with more specific questions regarding any flashbacks, nightmares, any panic attacks, etc. Okay. That is, you ask specific questions to perhaps refocus on a particular anxiety or anxiety spectrum disorder. If a patient or a person tells you, no, I do not consider myself, or I am not an anxious person, that reply has about a 99% negative predictive value. So it's a wonderful screening question as part of your psychiatric review of systems. Again, I would suspect that Elaine probably would say yes to that question. And whether it's during your diagnostic interview with regard to your initial assessment, or whether you take note that this is a series of follow-up questions that you're going to ask perhaps as early as your second session with Elaine, you'll begin to tease out what specific anxiety disorder that she might be experiencing. So, any other thoughts? Again, I do think she's going to endorse some of these signs and symptoms. From a little bit of a different perspective, when she does, what two things must the clinician always consider before perhaps evaluating for those specific anxiety disorders?
What is the, I think, a medical cause of it? So perhaps trying to get some labs, TSH value, something like that, that could be causing that increased nervousness and anxiety.
Absolutely. The clinician must always rule out, no matter what signs and symptoms are endorsed by Elaine, by anyone else, that these are not physical manifestations, behavioral manifestations of an underlying medical condition. And then what's the other aspect that clinicians must always investigate before attributing those signs to a mental disorder?
They could also check for substances.
Right. Absolutely. That's it, right? So substance induced mood / anxiety / other disorder versus that due to another medical condition. Now, there is a set of illnesses that are kind of in a gray area. The American Psychiatric Association lists them as psychiatric disorders. I absolutely think that they are medical conditions. So this grouping are referred to or is referred to as the sleep disorders, or as of 2013 in the DSM-5, these sleep-wake disorders. Be very careful. What comment was made prior is absolutely correct. An individual who has a mental disorder such as depression can absolutely have sleep deprivation, difficulty falling asleep, insomnia as a result of that. But it also works in the other direction. And if somebody comes in, and even if they meet full criteria for, let's say, depression, right? Depressed mood, anhedonia, psyche caps, we still have to rule out underlying medical conditions. And I submit that the sleep-wake disorders are examples of medical conditions. And the sleep disorder that I think we need to think about when Elaine comes to us and tells us that she's having these vivid dreams, and again, we're taking this concretely, they follow her to her bathroom, to other aspects of her life outside the bedroom, right? That's the quote. And she's exhausted, plopping herself on a couch. The clinician may attribute that to something called excessive daytime sleepiness. What sleep disorder does this sound like?
I mean, narcolepsy.
Yeah. I mean, you have a woman who's complaining of excessive daytime sleepiness and vivid dreams that are pervasive outside of the bedroom. That's got to be narcolepsy until proven otherwise. And if you provide a polysomnography, a sleep study, and she rules in, treating the narcolepsy may in fact alleviate signs of anxiety, depression, etc. So again, putting that medical condition first, the evaluation and treatment, and then following your patient to see if those behavioral signs and symptoms resolve is best practice. What type of sleep study, what type of polysomnography are you going to refer Elaine to here? It's called a multiple sleep latency test. Individual comes in, we'll call her Elaine. You provide 10 or 15 minute mini naps, and you wake them up after each mini nap and then allow them to fall asleep again. Individuals should not go into REM in that short of time. To do so would be pathologic. There are things that could be false positives. We're not going to get into that. But suffice it to say that a given percentage of REM that invades those mini naps is diagnostic for narcolepsy. So that's the multiple sleep latency test, multiple interrupted naps to see if in fact sleep latency is invaded. From that perspective, Elaine may or may not rule in for narcolepsy. And if she does, what medications would then the prescriber consider as part of a biopsychosocial treatment plan for Elaine?
So do you use modafinil and stimulants for narcolepsy?
Yes. So a stimulant in the morning, that's going to focus on the excessive daytime sleepiness. And then what might you provide at bedtime?
Melatonin? I'm not really sure for nighttime.
So identifying that narcolepsy is a REM pathology, right? It's REM intrusion into non-REM states. What might you think of?
Benzo?
Not a benzo, usually a tricyclic antidepressant, right? You want to disrupt REM. So it's usually a tricyclic antidepressant, an antidepressant with high anticholinergic potential, which disrupts REM and therefore disrupts narcolepsy. So a sedating anticholinergic medication at night, usually in the TCA class, combined with a stimulant first thing in the morning is usually the prescribing practice with regard to focusing on narcolepsy. Now, there's others too. You mentioned the benzo. There are other FDA-approved medications, including benzodiazepines for narcolepsy, in as much as they also will disrupt REM. All right, we are at the bottom of the hour. Any final thoughts about this episode?
I just wanted to bring up really quick George's boss in this episode. He basically just didn't care about anything, very apathetic. They say multiple times how his business was disorganized. When George blew up at him, he didn't care, let him keep his job. Although it was revealed that the incident, however many years ago, was actually instigated by him. Like, he thought it would be funny to throw his stuff in the water. So I just thought that was very interesting.
Yeah, I think my initial thoughts here certainly would include depression. We see someone who really would be at the apex of his career. And if he were to present with clinically significant apathy, anhedonia, I'm wondering whether or not he is struggling with generativity, right? So at some point, middle age, Ericksonian psychosocial stage theory, an individual is going to look into the mirror and ask, is this it? And for this particular character, to say yes may be threatening. To accept that all of your dreams and all of your ambitions have ended up here today may be something that's a struggle. So certainly clinical depression, but really in terms of etiology, tapping into social learning theory, Erik Erikson, I think a character that's struggling with generativity. On the other hand, as part of a routine psychiatric assessment, we are going to ask how long. If you're endorsing CE caps, how long have you been enduring these? Certainly, if you could give us a timeline, was there a precipitant? And if we're not really sure after further questioning that this is a major depressive episode, one thing to consider here, especially with the revelation, at the end of this episode, maybe what we're seeing is avoidance behavior, because and avoidance here I'm using as a defense mechanism, because he cannot have that thought of what he did to George come to conscious awareness. So George's presence may be subconsciously cueing him to a behavior that he had years ago. And he does not want to allow that to come to conscious awareness. So the ego will set a defense to ensure that that doesn't happen, and that might be avoidance. And individuals who maladaptively use the defense mechanism avoidance can actually present with a flat, moody, congruent affect. And that could be what's going on here, and certainly would be higher in our differential if other aspects of major depressive disorder don't quite work out, right? When we try to establish the history of present illness. So that's something to consider as well. All right, we're right at the bottom of the hour, so we'll end here. And for medical students, I will see you for rounds at about 9 o'clock. And then for everybody else, joining us back at 12:30 for a film discussion. See everybody back then.